Hi everyone, and welcome to the Otolaryngologic Clinics podcast series. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the August 2024 issue dedicated to dysphagia in adults and children. Guest edited by Drs. Masumi Sayamal and Eileen Rayner. Here now is consulting editor Dr. Sujana Chandrasekhar to lead the discussion.
Hello, I'm Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. And today I'm speaking with Dr. Masumi Natalie Sayamal and Dr. Eileen M. Rayner, who are the guest editors of the August 2024 issue of Clinics, which is on dysphagia in adults and children. Dr. Sayamal has recently returned to the East Coast of the United States and is the director of the Philadelphia Voice and Airway Institute in Philadelphia, Pennsylvania. Dr. Rayner is chief of the Division of Pediatric Otolaryngology and associate professor of head and neck surgery and pediatrics at Duke University Medical Center in Durham, North Carolina. They have put together an excellent comprehensive issue on swallowing issues in all ages. The 18 articles are written by leaders in the field, and there's some really great video content online as well. You can get this and all issues of Otolaryngologic Clinics of North America at www.oto.theclinics.com or in your personal or institutional library. All issues of Clinics since 2017 have an accompanying podcast, which can be accessed at the same website or wherever you get your podcasts, and they are, of course, free to all. Welcome, Masumi and Eileen.
Yay! Thank you for having us. We're so excited to bite into some dysphagia today.
Thank you so much. This is going to be very fun.
I think so. So let's get right into it and start talking dysphagia. So let's start with evaluation. So Eileen, Dr. Rayner, what are some key considerations when you're evaluating an infant or a child for concerns about dysphagia, and how does that change as the child grows?
So there are quite a few different things. Number one would be the age of the child, because it can make a really big difference if they're a newborn versus a toddler versus a, older child. Things that we are looking at is, how are they feeding? Are they breastfeeding? Are they bottle feeding? Are they spoon feeding? Like, what kind of feeding are they taking? What sort of consistencies are they taking? We look at how they're growing. So we're curious about if they're having challenges meeting their milestones, or if they're having failure to thrive, or if they're having concomitant breathing problems like stridor that may impact their feeding. And then anatomic considerations such as small jaw or tongue tie or a cleft palate or other things that may predispose them to feeding problems. And then we also are looking at what kind of symptoms are they having when they're feeding. Are they having more noisy breathing? Are they coughing and choking? Are they tearing? Are they actually refusing to latch on a bottle or on the breast? So all of those things are pretty important to sort of start that process and figure out how to get them on the right track.
So I think in the article that you wrote to start off this issue, you have some really nice video content about how one goes about examining children, who are, as we all know, not the most easy people to examine comprehensively. And I think you've included a very nice flow chart of assessment options, which I direct our listeners to. So interestingly, I think you have two different ways that we evaluate when we look at younger people and then when we look at adults. So Masumi, what are some of the key concepts when we assess an adult with dysphagia or with complaints of dysphagia?
Sure. I think one of the biggest things I try to do when a patient's in front of me is, in your head, you're kind of stratifying where in the dance of swallowing someone is off. But the big questions I tend to ask is the person losing weight because of the problem swallowing? that really puts in my mind how serious off the start and kind of guides my workup. There's a lot of good questions we can ask about whether or not meal times are taking too long. Is the person having issue with solids or liquids? Are they bringing up undigested food? Are there neurological changes, mental status changes? How is their voice? Are there issues where they're breathing, just like Dr. Rayner said, when we're assessing the child? Similar things. And then here with adults, we can really kind of assume that they're going to be pretty good historians and ask them, well, if you feel like something's getting stuck, is that the case? Where are you feeling it getting stuck? They can really help us try to find the diagnosis. And so the patient's really your best detective here in trying to help you solve their mystery.
And I think one of the other things that I've seen over time is that, yes, the adult patient should be able to help you, but in the circumstance where they are not able to help you, often their partner is able to help you, right? Often their partner can
Partners,
say,
caregivers,
right,
family members. Yep, they're invaluable. Absolutely.
So and by the same token, I think, Eileen, just circling back, parents have different ways that they learn how a child is quote unquote normal, right? So they have all these 1 million books, not just what to expect, but there are a plethora of materials out there that are books or social media stuff. There also are grandmothers and grandfathers and aunties and uncles and everybody else who knows everything. So how do you help especially first-time parents, separate the wheat from the chaff in terms of what is within normal limits for a child's eating or weight gain, or what is an acceptable, initial weight loss when they come home from delivery?
Yeah, so I think that's the thing. There's a lot of input. They're getting stuff from their friends, from moms groups, from social media, from TikTok, you name it, they're getting it. So it can be pretty challenging because a lot of times people come in and they sort of have these preconceived ideas of what's happening. So of course, going through the history, going through the physical exam, making sure about their birth history. Are they premature or are they full term? Was there any issues initially before they even were discharged from the hospital? And then, whatever physical exam findings. And so if everything is normal and they're on their growth curve, even if they're a smaller baby, but they're following their growth curve, that can provide a lot of reassurance to families. And it's common for newborns to lose a little bit of weight initially and then make it up. Sometimes it's just related to the consistency of the breast milk if moms are breastfeeding. And also engaging their primary care provider, their pediatrician in that discussion, because parents trust their pediatricians. And so having that as your sort of backup gives parents a lot of reassurance, especially in a normal situation. In an abnormal situation, or if there's a concern, engaging a feeding therapist and having a formal feeding evaluation. And, that chapter kind of goes through those evaluations and how that's done. And there's sort of a spectrum of what's done for that. But that can also provide assurance or guidance in terms of whether they need additional therapy or not.
So as we look to the our colleagues who can help parents and sort of guide in terms of swallow, we have people who come in, right from the get-go to help teach young mothers or new mothers how babies latch and how to make sure that that if they are in fact nursing, how that is to be done most optimally. What are the comorbid conditions where we might see difficulty very early on with either latching or sucking in enough, whether it's from the breast or the bottle? And then what happens in particular circumstances, like children with either submucous cleft or actual cleft palates?
Yeah, so there's a variety of comorbid conditions from mild things like a slightly smaller jaw to pretty significant things like neuromuscular issues. So we'll see children who have craniofacial anomalies. Cleft palate is a great example, submucous cleft or an overt cleft palate. And so those children need some special assistance to be able to feed properly. Down syndrome children, they have a slow tone, they have a large tongue, they have a shallow, like posterior nasopharynx and oropharynx, and all of that can influence the ability to effectively swallow. Children with other syndromes that cause macroglossia, like Beckwith-Wiedemann syndrome, and even tongue tie, which is a very controversial topic, especially in mild tongue tie. There are some cases where it's very clear there is no protrusion, there's no elevation, and those are fairly straightforward. There's a lot of them that are sort of in the gray zone, and I talk to families a lot about that. And then positioning the baby in different ways, trying different bottle types, and of course, working with our feeding therapists is pretty important. But there's quite a lot of different conditions that can play a role in how well a child can be an oral feeder.
Yeah, so I think, you touched on tongue tie, and I just want to inform our listeners, there seems to be quite a cottage industry in identifying and treating tongue tie that most otolaryngologists would not feel is a pathological condition or an abnormal condition. So I think caveat emptor for that diagnosis, and I think it's really very, very important that the buyer is in fact aware and maybe seeks, as you said, guidance from the pediatrician, guidance from the otolaryngologist, and maybe even a team approach with a pediatric dentist, right? This may be a place where, taking a beat and really thinking about it before subjecting the child to some intervention may be quite beneficial. Particularly, as I said, if they are on their growth curve, if they're sort of doing what they're supposed to do, but they happen to be, just a smaller person on their correct growth curve. I think that is very important. So Masumi, you had talked about asking adults where it sticks, right? And it's very interesting. Over this past Thanksgiving, you actually pointed out that people do get big. The food in America is so plentiful on that particular Thursday that
Yes.
we are just bowling down the food. We forget about the whole teeth and tongue and saliva part of swallowing and just kind of get right to the esophagus. So, how accurate can a patient be, an adult patient, when they point to their mid neck, their lower neck, or maybe somewhere in their chest, if they tell you that's where things get stuck?
So again, you have to kind of take a lot of things into consideration, but in general, patients are pretty accurate and a lot of times can even tell you what it is. Now, again, this depends on their mental status. Are they able to feed themselves? Esophageal foreign bodies in the throat do happen. Fish bones. I had posted online about a gentleman who had eaten a turkey, and so that was part of the wishbone. And this was a gentleman that actually told me where it was. And so when I went to assess him in the ER and took a look, I was like, yep, you're 100% right. But we also have to keep in mind the anatomy, and it's almost like a network of nerves and nerve fibers. And so sometimes patients can get the general vicinity, but they may not always pinpoint it because there are crossover of fibers, depending more so in the oropharynx and the pharynx and the supraglottis, the upper part of the larynx. In the esophagus, I've had a patient who has, I think, at one point was partially had early stages of dementia, but was able to identify that he had swallowed a bottle cap and knew kind of where it was. But because he was partially in the early stages of dementia, getting him proper care early on was difficult. So when people say it sticks, I always err on the side of believing them, because it's nothing on you to check, and to check really, really closely. It involves a scope for us. And I always kind of scope via quadrants. So I kind of set up a grid in my mind so I don't miss an area. If you are an otolaryngologist that has the ability to use light filters or NBI, it can actually catch the light in different ways, and you can find occult foreign bodies a little bit easier. For example, if you see a network of vessels that don't seem symmetric, that can sometimes guide you to where a translucent fishbone could be. So for the listeners there, I always try to methodically examine every patient every time, and I err to believe them.
So I think the methodical nature of this is really very important, right? And it's very important in all age groups. Both of you have said it. There's a really, really nice flow chart in the article called Esophageal Dysphagia in Adults When It Sticks by Richmond, DeVore, and Song. And you may have to put on a pair of glasses to read it, but hopefully online you can blow it up. But the concept of like asking where it is, sort of allowing that to be your guide, but as you said, looking before and after that point to make sure is really important. And we know that certain things get unstuck, right? Certain things manage themselves. Certain things don't. Certain things pierce the esophagus and give you mediastinitis, right? So certain things are very dangerous.
Most foreign bodies will pass.
Okay, so talk to us about what. So when the person comes and they feel this, and you see this, and you ask them what they ate, then what happens?
So if they can identify what they've eaten, there's another flow chart that we can take a look at, and we can kind of characterize, is it something sharp? Is it not sharp? Is it food material? We really want food boluses to pass within 24 hours. If it is a sharp object, if it is a long object greater than 6 centimeters, or if its diameter is greater than 2.5 centimeters, or if it's something caustic like batteries, which Dr. Rayner will go into more, or magnets, those are things that should get our blood pressure up. And we shouldn't let the sun set on those items. There's a special consideration for drug packets, which we see in the adult population, and those depends on the timing, whether they were encased. You want to hope they'll pass without bursting open. You don't want to burst them open and retrieving it. But in general, 2.5 centimeter diameter, sharp objects, batteries, magnets, anything longer than 6 centimeters, you want to immediately retrieve. And then other things, you have about 24 hours, don't let the sun set on it. Give the patient 24 hours, don't let a whole day pass. If things aren't passing, then you worry about perforation, which can happen in about 1 to 2% of people.
Yeah, so I, it's so funny. Other than in the movies, I don't really think about drug mules, but certainly that is something to remember. So let's talk a bit about aspiration. So Dr. Rayner, children with underlying airway anomalies are particularly susceptible to aspiration when they have some dysphagia element. So how do we identify these children, and how do we potentially repair whatever their airway thing is so that they can in fact go ahead and swallow safely?
Yeah, so certainly starting with the assessment and the history, as we've said the whole time, these may require doing some kind of a study, like a video swallow or a FEES, to see if they are in fact aspirating and what consistencies they're aspirating.
And FEAST means?
Fiber optic evaluation, endoscopic evaluation of swallowing. So that can be done in a breastfeeding baby. or a bottle fed baby. And basically, you have a fiber optic scope that's put in the nose, and you're watching them swallow. And you'll get a little whiteout effect when the palate kind of hits the tip of the scope, but you can actually see if there is penetration or aspiration of contents into the glottis. Some people will color the formula. You obviously can't color the breast milk, but you can see breast milk compared to saliva. So those are some good ways to assess it. And then really the gold standard is doing a direct laryngoscopy, where you're looking at the vocal folds and the subglottis and into the trachea, palpation of the posterior aspect of the cricoid, and the cricoid looking for a laryngeal cleft or a laryngeal notch or a groove. Other people call those a deep groove if they're a type 1, but they can extend pretty far below the vocal cords and be a big reason for aspiration. Evaluating for tracheoesophageal fistulas, tracheomalacia, tracheocompression from an external, like a blood vessel, and involving pulmonary and gastroenterology in some of these complex cases is very helpful. The treatment depends on the problem. So for laryngomalacia that may be causing aspiration, typically the treatment for that could be a supraglottoplasty. Fortunately, about 90% of children with laryngomalacia will outgrow it without needing any surgical intervention. But children who have failure to thrive or apnea, or there's just severe parental worry, things like that, they may be best served with a surgical intervention. And then for a laryngeal cleft, again, depending on the severity, the repair can vary from an injection into the area with just some kind of resorbable material like a gel versus a formal endoscopic repair. Again, depending on the severity and the concern for persistent aspiration. So, but also continuing that diligent monitoring afterwards too. So once you've done the intervention, that doesn't necessarily mean you're out of the woods. You want to kind of keep an eye on them. You may have to repeat some kind of instrumented swallow study, depending on how they're doing. And you want to kind of make sure that they do actually do well and you don't have to do anything else.
And then as you follow these children, do you have sort of just check-ins with your team? Like this must be a multidisciplinary approach, right, Eileen? So is there a social worker or a nurse or a nutritionist or someone who kind of follows up for a month, 3 months, 6 months to just make sure the child is on the right track?
Yeah, so typically these kids may be followed through an aerodigestive team, which would consist of GI, pulmonary, speech therapy, nutrition, social work. They may not be seen in that team more than once a year, depending on what's going on with them, but then they would definitely have regular follow-up with the different specialties involved, as well as their primary care provider. We frequently will follow these children pretty closely to make sure that they're doing well from an airway standpoint, as well as from a growth standpoint. And if there's a concern that things are not going in the direction we would like, we loop everybody back in. So they are definitely getting pretty close follow-up through a variety of specialists. Not every center has a formal aerodigestive team, and so they may be seeing the specialists at different times, but usually they'll at least be involved with those different specialties.
And the communication, I assume, between the team members is somewhat facilitated, probably very much facilitated with the electronic health record now.
Absolutely, yeah. So there's a lot of ways to route chart notes to people, to send staff messages to people. The nice thing about some of the records, which we use, and probably you guys all use too, is that you can actually see if they've gone to another center and you can talk to them. So we have patients that may be seen at one of our collaborating / competitive sites for other specialties, and we interact with them through that electronic record as well.
That's wonderful. So Masumi, you and I had talked some time ago about head and neck cancer and dysphagia, as an oncologist often does. I was at a grand round listening to dysphagia by somebody else, and the point was made that somehow our patients with head and neck cancer with chronic mild aspiration, So they're just a chronically little bit of aspiration all the time. They don't seem to get any of the secondary pneumonia or other tracheal or lung complications. Is that something you perceive? And how is dysphagia managed differently in patients who have underlying head and neck cancer pre and post treatment?
I love this question because it's such an interesting way of looking at our head and neck cancer patients. What I'll say is the caveat to that observation is that head and neck cancer patients who are plugged into treatment programs with good monitoring and have a multidisciplinary approach do have less of a concern, even though they may have some minor chronic aspiration. And that's because if you compare it to somebody who's chronically aspirating, but not having regular scope exams, every 6 weeks, every 8 weeks, every 12 weeks, however long, or aren't plugged into multidisciplinary teams, or aren't having regular chest scans, things can escape the minor phase and go into that major phase. And so some of this is the way we're observing these patients. We're observing them much more closely than we would, say, a person who's aspirating at home and we had no idea. The other part of this is with head and neck cancer patients, we approach swallowing, now that we have all this knowledge, very differently. We start with giving them pre-treatment assessments now because we know having a pre-treatment baseline, especially prior to radiation, is important. We have these multidisciplinary teams because it does take that village, looking at their lungs, looking at their swallowing, looking at their functional health, their psychiatric health. All of these things are important and a little bit different than how we tend to approach the average patient walking into our office with dysphagia. But it really is a lovely model for how we would want to treat all our patients. Then the other thing about head and neck cancer patients is there's some really good questionnaires and quality of life opportunities because you are seeing these patients every so many set weeks that you can monitor progression, you can monitor worsening a bit closer. And the last thing you really want to keep in mind when dealing with head and neck cancer patients with dysphagia is giving them their autonomy. They get to decide how much treatment they want, what they want to live with, what they don't want to live with. And keeping that in mind in the realm of cancer treatment and dysphagia is an important thing to do a little bit differently. But we always want to keep patient autonomy in mind, especially with dysphagia as we gracefully age. But in head and neck cancer, these are discussions we might want to have even earlier. Would you want a PEG tube if you can't swallow? If so, how long? Would you want tube feeds? Do you want to continue therapy all during your radiation, which are things that we do?
I liked all of this issue of clinics, but there is a really great table looking at different functional swallowing scales in the article on dysphagia and head and neck
Rajasekharan,
cancer.
yeah.
Yeah, so Lakshmipati, Alibone, and Rajasekharan. And I think using these scales is really great because I think it really allows you to stratify your thinking properly, and you can actually compare apples to apples as the treatment progresses, or unfortunately, if the tumor progresses, or they need another type of treatment. I think using these scales takes some of the subjectivity from the examiner out of
and
it.
makes it objective or a little more objective so we can really say, hey, the trend of these numbers. Absolutely.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
So I'm Dr. Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. Today I am speaking with Dr. Masumi Sayamal and Dr. Eileen Rayner, who are the guest editors of the August 2024 issue of Clinics, which is on dysphagia in adults and children. You can find this and all issues of Otolaryngologic Clinics of North America at www.odo.theclinics.com or your institutional or hopefully personal library. And you can find a podcast per issue since 2017 at that website or wherever you get your podcasts. Let's get back to our discussion. So, Eileen, with children who have underlying neurological conditions and motor weakness, which you've mentioned, how do you identify oral feeding issues and achieve the goals of nutrition, so that that child can just move it along and thrive?
Yeah, so these can definitely be some challenging children. We'll see children with epilepsy or muscular dystrophy or a host of neurologic conditions that really vary in severity, from a child being essentially, spastic quadriplegic in a specialized wheelchair and nonverbal to someone who really functions relatively well. And in many cases, you have to start slowly. So a lot of these children really may have challenges becoming oral feeders. And when they're coming out of the NICU, if they're preterm, or even if they're not and they have this underlying neurologic finding, a lot of times they will still end up in the NICU. They may be starting out on NG tube feeds, and they may ultimately need gastrostomy or jejunostomy tube feedings. But the thing is, depending on how they're doing, there's still potential for them to at least learn to acquire some tastes, or potentially even could be oral feeders on a limited type diet. But that's something that may not be figured out immediately. And I think one of the biggest things is trying to set expectations for families that it may be difficult to know, and we will continue to work towards it. They may never be a completely oral feeder. They may only be able to do a little taste. They may be able to eat many things. They may have a limited diet. They may be completely NPO due to chronic aspiration. So there's a very large range. And the other piece of that is really for them to expect that there will be setbacks, because if they have any kind of uptick in their seizures or infections or regression of their milestones, or even having had surgery, can set them back. So they need to be prepared for those and not think that now my child is never going to be eating again. And I think that's one of the things that's really important, is having those conversations early, and also kind of revisiting those conversations, because things do change over time. And I try very hard to give people hope when it's reasonable. Certainly having a good relationship with your feeding team and nutrition, looking at both what their caloric and protein intake needs are, their water needs are, and what can they safely potentially swallow orally versus not. And then managing salivary secretions in these kids is very important too. A lot of these kids have issues with poor salivary control, poor oral motor control, they drool. So there's medications and surgical procedures that sometimes have to be done to help control some of that, so they're not just aspirating their saliva as well. But it's a long journey, and I think the key is being part of that team and providing reassurance to families, and when possible, connecting them to other family networks.
When I was reading about this in the clinics, I was thinking about I belonged to this mommy and baby group when my oldest was born, and he's turning 29 this month. And there was one kid in the group who was a little hypotonal and maybe a little bit of a preemie and a little bit of this and a little bit of that. And, the mom, I looked at, really, other than sleep deprivation, how relatively easy I had it, right? And how, very focused she was, very concerned. And then I remember that his team beat my son's team in baseball a few times in high school. And then I remember the graduation, and then he went to college. And it's so nice to see the end result of all of these interventions. And I think sometimes, as physicians, we see them for 15-minute, 20-minute visits, every so often, and we talk about this. But as a mom in town, I was able to see the other side of it. I thought about that kid a lot reading this article and thinking about the magic that you guys do in these teams. So thank you.
And in these kids, really quick, sorry,
Yeah.
we will frequently see them far more than their primary care. It's really, like you were saying, it is so cool to watch them from, birth and the various struggles to high school graduation and just the progression. And one of the things I love to do when they see the kids in the clinic is ask them, what are they going to do when they finish school? And what do they want to be? And what are their interests? And they all light up and the parents light up. And it's just, it's really great to plant those seeds.
I completely agree. That's our touchy-feely part of this podcast. So now the three surgeons will continue to talk about surgery. So Masumi, dysphagia from a neurological cause in adults presents a little differently. So can you talk to us about some of the neurological things that do cause swallow issues in adults?
Sure. The big one that we all think of is stroke or, TIAs or cerebrovascular accident. But there's other ways and other neurological symptoms where the earliest signs or symptoms of these disorders might be a little difficulty swallowing. Parkinson's disease, ALS, multiple sclerosis, ALS, amyotrophic lateral sclerosis, all of these neurological diseases, some of the earliest or even first symptoms could be difficulty swallowing, which is again why it's so important that we do an amazing history. But the other end of this that, I'm hearing as we're all talking is that the main theme is it really takes a village. We're not silos. We need to tap into the expertise of our neurologists, our gastroenterologists, our nutritionists, our speech language pathologists. Often when I'm just not sure and something seems off, a person's relatively young, let's say they seem very healthy, something's a little off in the swallow, my speech language pathologist has picked up early Parkinson's or early ALS in a patient. So really, we have to recruit the village. We have to think of these neurological symptoms, but we also have to do it carefully because we might have a suspicion, but this might be the first sign of a neurological diagnosis, which is in so many ways life-altering for these patients.
So I think maybe the question I need to follow up with is, as an otologist, I hear my patients as they get older being told, oh yeah, you're dizzy. Everyone's dizzy when they're old. Oh, you can't hear. No one can hear when they're old. Lots of things are, oh, you're old. So how will the primary care physician or the geriatrician distinguish to send the patient appropriately when there's some just random, I guess there's some, presbyphagia, right? Some swallowing
Sure.
issues that just sort of happen. And we'll talk about that in a little bit. But how do we guide our colleagues to maintain the index of suspicion to get those patients to you and your team?
This is where I tell my residents this, I tell my med students this is where just starting by looking the patient as a whole helps a lot. Notice if there's a slight tremor. Have them come grab something off your table. Listen and watch their eyes. A lot of times I find when I'm suspecting a neurological cause of dysphagia, there'll be other cranial nerve deficits that are slight, or other neurological findings that people haven't quite put together. Asking if you've had a lot of falls. Are you dropping things a lot? Are meal times just taking a lot longer? Do you feel uncoordinated? A big thing, and Dr. Devan talks about this in her chapter about oropharyngeal dysphagia, tongue strength. Do you feel tongue strength has declined? Watching their tongue, seeing if there's deviation or fasciculations, watching their palate elevate. Really look at the whole patient. I know we're looking at the larynx per se, or looking at the ear, nose, and throat aspect of it, but it takes nothing for us to have the examination start the second you open that door. And sitting in silence and kind of watching the patient relax or at ease sometimes will even reveal tremors, reveal posturing and limbs, or, you can find a lot by just watching. And then again, recruiting our other experts. If you're unsure, get another second set of eyes on it.
Eileen, we had briefly mentioned foreign bodies, and foreign bodies and caustic ingestion are a real issue in pediatric practice. They not only are horrible in the short term, but they can cause long-term effects. I remember hearing about somebody storing lye and some detergent and some sort of like lighter fluid for their grill in milk containers, and a child reaching and taking a big swig of milk. And this was actually considered to be part of the spectrum of child abuse and neglect, because you're not supposed to make something look like milk if it's going to really hurt you. So that's a very long preamble. So what do kids swallow? How does a multidisciplinary team improve outcomes when such a thing has happened?
Yeah, so I actually have a kid like that who at 2, parents had put some kind of cleaning liquid in like a water bottle or Sprite bottle or something, and they swallowed it and, developed a lot of long-term esophageal and pharyngeal strictures. He is now a junior in high school, but he still has issues with things getting stuck and having to have repeat endoscopies and dilations and things like that. So it is a chronic condition and a chronic problem. And it really does depend a lot on what the foreign body or the caustic ingestion material is in terms of how severe the injury will be. Also, when was it recognized? Was it immediate? Was it delayed? We definitely work a lot with GI on these patients because they frequently do need repeat endoscopies, and they may need dilations or other interventions. There's some that may need lysis of adhesions where they get pharyngeal strictures that can actually affect the supraglottic area as well. So depending on where the ingestion is, what the type of material was, those effects can be pretty significant and long lasting, to the point where they may develop a complete stricture and end up needing gastrostomy type feeding. And so really working with the feeding team. Also, in some cases, even if there isn't a underlying pathological stricture or other issue from the ingestion, it could also lead to psychological problems where now they're afraid to eat and they develop oral aversion or fear of eating, especially if this happened at a younger age. And exactly like Dr. Smile said, if you have a sharp object, or you have an object that causes an esophageal perforation or even migrates somewhere into the neck or the mediastinum, I mean, that becomes a significantly more challenging and complicated problem. And of course, button batteries is a huge issue. The American Academy of Pediatrics has a button battery. They have to be removed quickly because of the high risk of esophageal perforation, injury to the trachea, and the lethal risk of injury to the aorta, which has happened. And so there was a bill introduced, it's Reese's Law, where a child died from a button battery ingestion. There's been a lot of work on trying to make button batteries safer. Companies are doing different packaging. There's some technology out there to sort of change the electrical connectivity when it adheres to mucosa or is in contact with saliva. But there's a lot of work in that area.
In multi-generational families, people don't even realize that button batteries are there in hearing aids that can get lost. And as people do have rechargeable hearing aids, but many people use hearing aids that have tiny little batteries that maybe the hearing aid wearer can't see very well, but that little child crawling around the ground can see very well. And I think what you're talking about is some precautions with how the lock works when you use button batteries in toys, as well as changing the actual batteries. Is that right?
Yeah, but even things like car key fobs and digital thermometers, they like to use those C32 batteries, which are, they look like a quarter and they're about the same size and they're shiny and they're cute and, it's
They
attractive
fit
to
very
kids.
well inside somebody's mouth.
Yes, exactly. And so, fortunately, we have some nice radiological distinguishing features between button batteries and coins, where you can see a step off or you can see a double halo sign when there's a button battery. But, that's something that requires education of emergency physicians and urgent care physicians and providers, and really recognizing and knowing there's an urgency that needs to be transferred to a higher level of care for immediate management.
So the one thing I did want to point out before we move on from this is that there's a very excellent flow chart that looks at timing and time of intervention for caustic ingestions in the article that was written by Powers and Baldessari and Lucas. And I strongly recommend it because, again, it allows you to know what to act upon emergently, urgently, and what you can observe for a little bit at least. And I think, as Masumi, you pointed out that, things that are not going to hurt right away in adults, you have about 24 hours to watch. But as you pointed out in your article on adult esophageal foreign bodies, other risk factors for perforation include the patient having diabetes mellitus and the foreign body being there for longer than 24 hours. So I think time is of the essence in children and adults when we're talking about foreign body ingestion. Masumi, we don't often think about metabolic or endocrine disorders that affect swallowing, or maybe I don't, and I should. So, can you talk to us a little about which diseases in those realms affect swallowing and what should we know about that?
Yeah, I find this segment or this section of the book really, really interesting, because over the years, these are the types of patients that I think we tend to actually encounter more in clinic. And these tend to be my younger adult patients. And we are not really seeing any obvious foreign body. We're not seeing any obvious anatomical structure. So then the next place we should look is really these diseases of metabolism. And so for the audience there, that includes diabetes, which is a huge proportion of the American population, people with thyroid disorders of calcium metabolism, renal disorders, anything that's going to set your electrolytes off balance. Because if we take this back to med school, it's action potentials, it's contraction of myosin, calcium channels. All of those things move the muscles of swallow. Patients with Cushing's disease, patients who may be suffering from alcoholism and on, like a Wernicke's encephalopathy, can also have related muscle issues with swallowing as well. A new kind of element has been the use of GLP-1s. And GLP-1s, there's been some information out there that can sometimes even induce a Wernicke's-like encephalopathy or metabolic derangement. Our diabetic patients on these GLP-1s can complain of dysphagia, and we're seeing this more and more. This is a little out of the weeds, but when I see young people that seemingly are healthy, I worry about eating disorders. So seemingly very healthy, very thin, but their anatomy looks right. You worry about malnutrition, anorexia, bulimia. Those can cause major shifts in electrolytes as well. Another thing is young patients that are taking pre-workout supplements or creatine. They can suffer from electrolyte imbalances as well. They're working really hard at the gym. They're taking exogenous steroids. think about these patients that can have some difficulty swallowing. Otherwise, they might look healthy. They might seem like they have nothing going on. This is where we would look to.
That's really interesting. And I think that's very important as we see patients with varying other activities that they are doing. Eileen, we talked about young children and babies. What are some of the causes of delayed onset of dysphagia in older children?
Yeah, so they're kind of interesting because one of the more common things is some inflammatory conditions, with eosinophilic esophagitis being extremely common. It's more typical in boys, but it can occur in girls as well, and tends to show up either in the preteen years or even teenage years, and can present in a variety of ways. Frequently, it will look a lot like gastroesophageal reflux disease, but its treatment is quite different, and the diagnosis requires a biopsy. So that's typically done with our GI colleagues and endoscopy. And then rheumatologic conditions, which are less common, but things like scleroderma, even something like epidermolysis, could affect their esophagus and swallowing. And then just like Dr. Smile said, psychological feeding disorders and eating disorders is something, especially in preteen and teenage girls, that is concerning, but you will sometimes see that in boys as well. And then one of the more recent things that has come up is abelchia, where there's some kind of dysfunction of the cricopharyngeus muscle. And so children complain that they can't burp. And the muscle doesn't seem to relax to let gas escape out. And it can be extremely uncomfortable and painful for them. Or cricopharyngeal dysfunction can occur in children and in teenagers as well. So it's interesting, and trying to sort that out definitely requires kind of a several team member approach. You might have to loop in your endocrinologist or your rheumatologist and do some workup looking for some of these other conditions. You may be looking for things like juvenile arthritis or lupus even. So all of these underlying kind of conditions, autoimmune conditions, may have some impact on swallowing and cause some challenges.
Masumi, hopefully we'll all continue to get older. So are we inevitably going to have trouble swallowing, or how do we make it more quote unquote palatable? I know I'm very clever.
We would only be so lucky to all get older. What I'll say is, swallowing affects everyone to a certain degree. 300 to 600,000 adults are affected by dysphagia annually, and this is thought to be a gross underestimation. Now, most of these people are over the age of 60, 65 years old. But the big things that we can do, especially us women, is we need to prevent sarcopenia and muscle loss. And we do this by lifting weights. We do this by lifting heavy. So something that we don't think might be related right now, getting in a good weight training regimen. No better time than the present. I'm a huge proponent from that. Other than that, we really just need to remember swallowing is a use it or lose it function. So we want to keep doing it. And we want to keep eating things that are healthy, that have nutritional value. We want to chew well, not get distracted. And we want to also keep ourselves cognitively sharp. So all of those things are part of that big ballet, that choreography of the dance of swallow.
Thank you both so very much. I've been talking with Dr. Masumi Sayamal and Dr. Eileen Rayner. As we wrap up, can I ask you for a couple of takeaways for our audience? And I'll start with Dr. Eileen Rayner of Duke University.
One of the things is really kind of paying attention to, in children, babies especially, the suck, swallow, breathe, reflex and patterns. Pay attention to how they're breathing in addition to how they're swallowing, because those two are very interrelated. As children get older, start thinking about what are the different consistencies. Also think about other factors that may be contributing to their big picture, whether they're having some other underlying things like on the autism spectrum, and they may be very particular about what they eat. And even if the food doesn't, that it doesn't touch each other, or the amount, there's a lot of different interplays there. And remember that this is a complicated function and may require a multidisciplinary approach. It usually does. So having your colleagues and your team working with the patient and working with the families is essential to really getting the outcomes that everybody wants.
Thank you. Masumi, Dr. Sayamal from the Philadelphia Voice and Airway Institute in Philadelphia.
Thank you. Big things, I'll echo Dr. Rayner. It really does take a village. Resist the urge to just jump to a conclusion. Make sure you're doing a full comprehensive workup, examination. Utilize our smart colleagues in other disciplines, GI, neuro, nutrition, speech, psychiatry, and really use guidelines to help guide and direct our patient. Swallowing is a joy of life. Keep that in mind. And all we want to do is restore joy. And last but not least, then to our listeners, you don't have to remember this all. All of this is in our awesome little book and more. So all this complicated stuff that we're talking about, you don't even have to remember. Just do yourself a favor, go on, get the book, throw this on your desk, and anytime there's a patient with dysphagia, you just pull it up and you look it up. You're not going to be sorry. Thank you so much, Dr. Chandrasekhar, for allowing us to share the piece of the pie of dysphagia with you.
Yes, thank you so much. This has been a pleasure to do, and it's always fun talking about eating. Next time we'll have to talk about food, but very fun.
Well, thank you both so much. This really has been a pleasure working with both of you on creating this issue and bringing it to fruition, and then being able to record some of your thoughts with so many years of experience and wisdom. I'm Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America, and my wonderful guests today have been Dr. Masumi Sayamal, the director of the Philadelphia Voice and Airway Institute in Philadelphia, Pennsylvania, and Dr. Eileen Rayner, the chief of the Division of Pediatric Otolaryngology and associate professor of head and neck surgery and pediatrics at Duke University Medical Center in beautiful Durham, North Carolina. You can get this issue and all issues of Otolaryngologic Clinics of North America at www.oto.theclinics.com, and hopefully in your personal library as well as in your institutional library. You can access the podcasts at the website or wherever you get your podcasts. Always looking for feedback, so please reach out to us and tell us how we can make things better. I hope you enjoy this issue and every issue. And again, I want to thank Masumi Sayamal and Eileen Rayner so much. This has been a lot of fun.
This has been great. If you want to follow me on Instagram, my handle is Dr. Mouse, where the S is a 5. Thank you.
Excellent.
Thank you so much.
I'm going to make a TikTok with the two of you. Don't worry.
That'd be great.